Okay, so trigeminal neuralgia. So this is also sometimes called tic-douloureux. Okay, so tic-douloureux, and this is in older patients. Okay, so already this kind of differentiates it from some of the other things that we talked about, right? Migraines, typically younger patients. Pseudotumor cerebri, typically younger patients. Again, this is going to be unilateral, right? Like most of the headaches are. Severe, sudden onset, shooting or stabbing electric shock-like pain. Now, when you see the electric shock pain, that's very, very classic for trigeminal neuralgia, particularly if you know the distribution, right? If it's in the V2, V3 distribution, which is going to be the maxillary and mandibular divisions of the trigeminal nerve, right? So if you have this, electric-like shooting or stabbing pain running down the jaw, for example, that's going to be very classic for trigeminal neuralgia, particularly in older patient. Okay, and look at this, the duration, several seconds. So that's going to be a huge differentiating factor from some of the other pathologies. Migraines, we said 4 to 72 hours. Cluster headaches, less than 3 hours. And here we have something that happens over several seconds. Okay, so this can occur, 50, 100 times a day. These patients can have these, very debilitating electric-like pain symptoms that happen many times throughout the day. And it's classically going to be with these triggers listed below. Now, on the other diseases I told you, there's a lot of overlap with stress and lack of sleep. But here with trigeminal neuralgia, the big thing is these certain triggers, when they're brought up in the question stem, it should really call your attention to this disease. So when the patient is talking, when they're chewing, when they're eating food, right, it's very painful to eat. They'll have this, shooting pain, down the jaw typically when they're eating, when they go to brush their teeth, right, when the toothbrush touches that portion of the nerve, right, in the mandibular division of the trigeminal nerve or maxillary division, right, that pain is going to be elicited. Okay, and so these patients, or even when the patient is shaving, right, an older patient, when they shave, they have very severe stabbing pain. That's very classic for trigeminal neuralgia. Again, MRI generally unremarkable. Now, the treatment here is different from some of the other treatment modalities we discussed. This is classically going to be carbamazepine. Now, remember, we talked a little bit about this when we talked about, sodium channels, action potentials, that, these anti-epileptics, some of these will classically inhibit the depolarizing sodium channels. Now, carbamazepine actually does this because it reduces the ability of sodium channels to recover from inactivation. So carbamazepine will target these sodium channels that are inactivated and then prevent them basically from recovering, causing further inactivation. Now, again, going back to the side effects, because on a board question, they can tell you, okay, they treated the patient with, carbamazepine, or they can tell you the patient has trigeminal neuralgia, they treated them with a medication. What's the major side effect to that medication? Okay, so it's important to know that, again, the big three, like we talked about with sumatriptan, these are my big three side effects to be aware of for carbamazepine. Number one, the highest yield, is definitely going to be aplastic anemia. Okay, so this is basically going to be bone marrow suppression of all three cell lines. So we're talking about platelets, we're talking about hemoglobin, we're talking about leukocytes. And the reticulocytes will classically be low, right? Because it's a myelosuppression. You're suppressing it at the site of the bone marrow. So, the classic question is, what test would you order in a patient that is on carbamazepine? And that answer is classically going to be a CBC, right? You want to be able to see their platelets, you want to see their hemoglobin, you want to see their white blood cells. The other thing here is going to be SIADH, right? Syndrome of inappropriate antidiuretic hormone release is very classic to be caused by carbamazepine. And the last thing I would remember on here is just Stevens-Johnson syndrome. Okay, and we'll talk more about these in future videos, but just to, put all the pieces out there so we have it in one place.